Good afternoon, dear colleagues. I bring to your attention a lecture of the course Prosthetic Dentistry, the purpose of which is to acquaint you with infection prevention practices in dental settings. About of basic expectations for safe care. About of sterilization and disinfection of patient care items and devices in general. And specifically, about of disinfection and sterilization in orthopedic dentistry clinic. The lecture is prepared by Associate Professor of the Department of Prosthetic Dentistry of Kharkiv National Medical University. MD, PhD, EDM. Vyacheslav Tomilin. Plan of lecture. 1. Introduction. 2. Hand hygiene. 3. Personal protective equipment. 4. Respiratory hygiene. Cough etiquette. 5. Sharp safety. 6. Safe injection practices. 7. Sterilization and disinfection of patient care items and devices. 8. Environmental infection prevention and control. 9. Dental unit water quality. Introduction. Administrative measures. Infection prevention must be made a priority in any dental health care setting. At least one individual with training in infection prevention, the Infection Prevention Coordinator, should be responsible for developing written infection prevention policies and procedures based on evidence-based guidelines, regulations, or standards. Policies and procedures should be tailored to the dental setting and reassessed on a regular basis, for example, annually, or according to state or federal requirements. Development should take into consideration the types of services provided by dental health care personnel and the patient population served, extending beyond the Occupational Safety and Health Administration bloodborne pathogen standard to address patient safety. The Infection Prevention Coordinator should ensure that equipment and supplies, for example, hand hygiene products, safer devices to reduce percutaneous injuries, and personal protective equipment, are available and should maintain communication with all staff members to address specific issues or concerns related to infection prevention. In addition, all dental settings should have policies and protocols for early detection and management of potentially infectious persons at initial points of patient encounter. Key administrative recommendations for dental settings. 1. Develop and maintain infection prevention and occupational health programs. 2. Provide supplies necessary for adherence to standard precautions, for example, hand hygiene products, safer devices to reduce percutaneous injuries, personal protective equipment. 3. Assign at least one individual trained in infection prevention responsibility for coordinating the program. 4. Develop and maintain written infection prevention policies and procedures appropriate for the services provided by the facility and based on evidence-based guidelines, regulations, or standards. 5. Facility has system for early detection and management of potentially infectious persons at initial points of patient encounter. Terminology. One of the main responsibilities of healthcare professionals is to create a safe and comfortable environment for their patients. Despite this, the American Dental Association, ADA, and the Centers for Disease Control, CDC, have developed protocols to prevent cross-contamination among dental patients. This involves thorough cleaning and sterilization of all types of dental instruments every time they are used on a patient. Before moving on to how cross-infection is ensured in dental practice, we will introduce you to some common terminology. Cleaning. Cleaning is an important process that is performed before sterilization and disinfection of dental instruments. This involves cleaning all surfaces of the dental instruments to remove blood, germs and debris and preparing the instruments for the dental sterilization process. Tools are usually cleaned with water or detergents. Disinfection. Disinfection is a process by which all germs are removed except for bacterial spores. Dental instruments are usually disinfected with liquid disinfectants. Sterilization, or sterilization, is a term referring to any process that eliminates, removes, or kills, deactivates, all forms of life and other biological agents, such as viruses which some do not consider to be alive but are biological pathogens nonetheless, excluding prions which cannot be killed, including transmissible agents, such as fungi, bacteria, viruses, prions, spore forms, unicellular eukaryotic organisms such as Plasmodium, etc., present in a specified region, such as a surface, a volume of fluid, medication, or in a compound such as biological culture media. Sterilization can be achieved with one or more of the following: heat, chemicals, irradiation, high pressure, and filtration. Sterilization is distinct from disinfection, sanitization, and pasteurization in that sterilization kills, deactivates, or eliminates all forms of life and other biological agents. Today's busy dental practices face a serious challenge: to maintain or increase productivity while ensuring that patient safety remains a top priority. At times, these may seem like incompatible goals. Advances in dental processing equipment, however, have empowered practices to develop safer processes while realizing efficiencies and ultimately, saving money. A cleaning and sterilization process that meets ETA and CDC guidelines is vital to an effective infection control program. Streamlining of this process requires an understanding of proper methods, materials, and devices. Many methods of instrument reprocessing are available. Use of a complete system that encompasses and fulfills all elements that are critical maximizes efficiency and minimizes risks. Closed cassette systems provide a more efficient and safer way to process, sterilize and organize instruments in a dental office. These eliminate manual steps during instrument reprocessing such as hand scrubbing and time-consuming sorting of instruments, thereby improving safety and increasing efficiency. Effective and efficient infection control in the dental office is essential for the safety of patients and to ensure that productivity does not suffer. Infection control programs all include the cleaning and sterilization of reusable dental instruments and devices. Care must be taken by the dental healthcare professional to ensure that all instruments are cleaned prior to sterilization, and that this is carried out in a safe manner to avoid injury and puncture wounds. Use of closed-system cassettes reduces the risk to dental healthcare professionals when executing infection control programs. When using ultrasonic cleaners, washers and sterilizers, it is important to always follow the manufacturer's instructions. It is also important to consult with the manufacturer of dental instruments and devices as needed to ensure complete sterilization and to avoid damage to these items. Assurance of sterility of instruments and devices can be obtained through the use of one of several tests, and these tests must be performed regularly to ensure that the sterilizer is sterilizing all instruments and devices and that these are safe for use on patients. Infection control, also called Exposure Control Plan by OSHA, Occupational Safety and Health Administration, is a required office program that is designed to protect personnel against risks of exposure to infection. Sterile. Does not contain live microorganisms. Usually described as a probability. For example, the probability of a microorganism surviving is 1 in 1 million. Disinfectant. A chemical agent used on inanimate objects to destroy virtually all recognized pathogenic microorganisms, but not necessarily all microbial forms. Asepsis. Prevention of microbial contamination of living tissues or sterile materials by excluding, removing or killing microorganisms. We are present to your attention the following definitions of the term disinfection. 1. Disinfection. This is destruction of pathogenic and other kinds of microorganisms by physical or chemical means. 2. Disinfection. This is a process of removing or killing most, but not all, viable organisms. By C. Mims, J. Playfair. 3. Disinfection refers to the destruction of pathogenic organisms. Ronald B. Luftig. 4. Disinfection, from French. De, negation and lot. Infectia, infection. This is the destruction of pathogenic microorganisms, bacteria, viruses, rickettsia, protozoa, fungi, their carriers, insects, ticks, as well as rodents in the human environment. Disinfection is an important part of sterilization. Disinfection is always at least a two-step procedure. The initial step involves vigorously cleaning and wiping the surfaces to be disinfected. The second stage involves wetting the surface with a disinfectant and leaving it wet for the time specified by the manufacturer. An ideal disinfectant has the following properties. 1. A wide range of activities. 2. Acts quickly. 3. Non-corrosive. 4. Environmentally friendly. 5. Does not contain volatile organic compounds. 6. Non-toxic and unstable. 7. High-level disinfection, a disinfection process that inactivates vegetative bacteria, mycobacteria, fungi and viruses, but not necessarily a large number of bacterial spores. 8. Intermediate disinfection, a disinfection process that inactivates vegetative bacteria, most fungi, mycobacteria, and most viruses, especially viruses that envelop, but not bacterial spores. 9. Low-level disinfectant liquid chemical germicide. OSHA, Occupational Safety and Health Administration, requires that low-level medicinal disinfectants also have an application for HIV, human immunodeficiency virus, and HBV, hepatitis B virus, potency labeling. 10. Gigacept containing succinylaldehyde and dimethoxytetrahydrofuran is used to disinfect plastic and rubber materials such as a dental chair. Purpose of disinfection: removal or destruction of the causative agent of infectious diseases and the environment surrounding a person, indoors, in the air, on furnishings, on dishes, linen, clothes, patient secretions, etc. Disinfection sections are: 1. Proper disinfection, destruction of pathogenic microorganisms. 2. Disinsection, destruction of disease vectors, insects, ticks. 3. Deratization, rodent extermination. 4. Sterilization, destruction of all microorganisms. Achievement of the above-mentioned goals can be realized in several ways. By means of preventive, final, and focal disinfection. In the first case, it means a set of measures aimed at preventing the spread of infections inside premises. In hospital wards, school classrooms, workshops of enterprises, offices of organizations. When the premises are not contaminated, a preventive procedure is performed. There are several types of such disinfection. Preventive disinfection, which is subdivided into routine, or scheduled, disinfection. Disinfection according to epidemiological indications. Disinfection according to sanitary and hygienic reasons. The next disinfection group is focal disinfection, which can be subdivided into focal current disinfection and focal final disinfection. Preventive disinfection is carried out constantly, regardless of the presence of a source of an infectious disease. Routine disinfection in this case provides for the disinfection of tools and equipment, minimization of the number of spreaders of bacteria, rodents and arthropods. Preventive disinfection, according to epidemiological indications, is carried out in rooms adjacent to those where the outbreak was recorded. Preventive disinfection according to sanitary and hygienic reasons is most often carried out in crowded places where, due to the unfavorable sanitary and hygienic situation, there is a high probability of focal infection, in kindergartens, schools, universities, hospitals, swimming pools. Focal current disinfection is carried out in the focus of infection in the presence of a patient or a bacillus carrier. The purpose of the current disinfection is the immediate destruction of the pathogen after it is excreted from the patient's body or the carrier of the bacillus. Focal final disinfection is carried out once in the focus of infection after isolation of the patient or the bacillus carrier. The goal is to completely disinfect objects that could be infected with the pathogen. The final disinfection is carried out in the foci of those infections, the causative agents of which are resistant in the environment. These include plague, cholera, infectious hepatitis A, viral hepatitis, etc. Hand hygiene. Review of the scientific data regarding hand hygiene. Historical perspective. For generations, Hand washing with soap and water has been considered a measure of personal hygiene. The concept of cleansing hands with an antiseptic agent probably emerged in the early 19th century. As early as 1822, a French pharmacist demonstrated that solutions containing chlorides of lime or soda could eradicate the foul odors associated with human corpses and that such solutions could be used as disinfectants and antiseptics. In a paper published in 1825, this pharmacist stated that physicians and other persons attending patients with contagious diseases would benefit from moistening their hands with a liquid chloride solution. In 1846, Ignaz Semmelweis observed that women whose babies were delivered by students and physicians in the first clinic at the General Hospital of Vienna consistently had a higher mortality rate than those whose babies were delivered by midwives in the second clinic. He noted that physicians who went directly from the autopsy suite to the obstetrics ward had a disagreeable odor on their hands despite washing their hands with soap and water upon entering the obstetrics clinic. He postulated that the puerperal fever that affected so many parturient women was caused by cadaverous particles transmitted from the autopsy suite to the obstetrics ward via the hands of students and physicians. Perhaps because of the known deodorizing effect of chlorine compounds, as of May 1847, he insisted that students and physicians clean their hands with a chlorine solution between each patient and the clinic. The maternal mortality rate in the first clinic subsequently dropped dramatically and remained low for years. This intervention by Semmelweis represents the first evidence indicating that cleansing heavily contaminated hands with an antiseptic agent between patient contacts may reduce healthcare-associated transmission of contagious diseases more effectively than hand washing with plain soap and water. In 1843, Oliver Wendell Holmes independently concluded that postpartum fever was transmitted through the hands of medical personnel. In 1988 and 1995, the Association for Professionals in Infection Control, APIC, published guidelines for hand washing and antisepsis. The recommended indications for hand washing were similar to those listed in the CDC, Centers for Disease Control, guidelines. In 1995 and 1996, the Healthcare Infection Control Practices Advisory Committee, HYGIENE, recommended the use of antimicrobial soap or anhydrous hand sanitizer when leaving a patient room with multi-drug-resistant pathogens. For example, vancomycin-resistant enterococci, VRE, and methicillin-resistant Staphylococcus aureus, MRSA. These guidelines also provided recommendations for hand washing and hand antisepsis in other clinical settings, including routine patient care. Although the APIC and HYGIENE guidelines have been adopted by the majority of hospitals, adherence of HCWs to recommended hand washing practices has remained low. Recent developments in the field have stimulated a review of the scientific data regarding hand hygiene and the development of new guidelines designed to improve hand hygiene practices in healthcare facilities. Definition of terms. Alcohol-based hand rub. An alcohol-containing preparation designed for application to the hands for reducing the number of viable microorganisms on the hands. In the United States, such preparations usually contain 60% to 95% ethanol or isopropanol. Antimicrobial soap. Soap, i.e., detergent, containing an antiseptic agent. Antiseptic agent. Antimicrobial substances that are applied to the skin to reduce the number of microbial flora. Examples include alcohols, chlorhexidine, chlorine, hexachlorophene, iodine, chloroxylenol, PCMX, quaternary ammonium compounds, and triclosan. Antiseptic hand wash. Washing hands with water and soap or other detergents containing an antiseptic agent. Antiseptic hand rub. Applying an antiseptic hand rub product to all surfaces of the hands to reduce the number of microorganisms present. Cumulative effect. A progressive decrease in the numbers of microorganisms recovered after repeated applications of a test material. Decontaminate hands. To reduce bacterial counts on hands by performing antiseptic hand rub or antiseptic hand wash. Detergent. Detergents, that is, Surfactants are compounds that possess a cleaning action. They are composed of both hydrophilic and lipophilic parts and can be divided into four groups: anionic, cationic, amphoteric, and non-ionic detergents. Although products used for hand washing or antiseptic hand wash in healthcare settings represent various types of detergents, the term soap is used to refer to such detergents in this guideline. Hand antisepsis refers to either antiseptic hand wash or antiseptic hand rub. Hand hygiene, a general term that applies to either hand washing, antiseptic hand wash, antiseptic hand rub, or surgical hand antisepsis. Hand washing, washing hands with plain, that is, non-antimicrobial, soap and water. Detergent, that is, surfactants, surface active substance, SAS, are compounds that possess a cleaning action. They are composed of both hydrophilic and lipophilic parts and can be divided into four groups: anionic detergents, cationic detergents, amphoteric detergents, and non-ionic detergents. Persistent activity. Persistent activity is defined as the prolonged or extended antimicrobial activity that prevents or inhibits the proliferation or survival of microorganisms after application of the product. This activity may be demonstrated by sampling a site several minutes or hours after application and demonstrating bacterial antimicrobial effectiveness when compared with a baseline level. This property also has been referred to as residual activity. Both substantive and non-substantive active ingredients can show a persistent effect if they substantially lower the number of bacteria during the wash period. Plain soap. Plain soap refers to detergents that do not contain antimicrobial agents or contain low concentrations of antimicrobial agents that are effective solely as preservatives. Substantivity. Substantivity is an attribute of certain active ingredients that adhere to the stratum corneum, that is, remain on the skin after rinsing or drying, to provide an inhibitory effect on the growth of bacteria remaining on the skin. Surgical hand antisepsis. Antiseptic hand wash or antiseptic hand rub performed preoperatively by surgical personnel to eliminate transient and reduce resident hand flora. Antiseptic detergent preparations often have persistent antimicrobial activity. Visibly soiled hands. Hands showing visible dirt or visibly contaminated with proteinaceous material, blood, or other body fluids, for example, fecal material or urine. Waterless antiseptic agent. An antiseptic agent that does not require use of exogenous water. After applying such an agent, the hands are rubbed together until the agent has dried. FDA, Food and Drug Administration, Product Categories. The 1994 FDA Tentative Final Monograph for Healthcare Antiseptic Drug Products divided products into three categories and defined them as follows. 1. Patient preoperative skin preparation. A fast-acting, broad-spectrum, and persistent antiseptic containing preparation that substantially reduces the number of microorganisms on intact skin. 2. Antiseptic hand wash or HCW, healthcare workers, hand wash. An antiseptic containing preparation designed for frequent use. It reduces the number of microorganisms on intact skin to an initial baseline level after adequate washing, rinsing, and drying. It is broad-spectrum, fast-acting, and if possible, persistent. 3. Surgical hand scrub. An antiseptic containing preparation that substantially reduces the number of microorganisms on intact skin. It is broad-spectrum, fast-acting, and persistent. Hand hygiene recommendations. Guidance for healthcare providers about hand hygiene and COVID-19. Hand hygiene is an important part response to the international emergence of COVID-19. Practicing hand hygiene, which includes the use of alcohol-based hand rub or hand washing, is a simple yet effective way to prevent the spread of pathogens and infections in healthcare settings. The exact contribution of hand hygiene to the reduction of direct and indirect spread of coronaviruses between people is currently unknown. However, hand washing mechanically removes pathogens, and laboratory data demonstrate formulations in the range of alcohol concentrations inactivate SARS-CoV-2. Hygiene methods. CDC recommends using ABHR, alcohol-based hand rub, with 60 to 95% alcohol in healthcare settings. Unless hands are visibly soiled, an alcohol-based hand rub is preferred over soap and water in most clinical situations due to evidence of better compliance compared to soap and water. Hand rubs are generally less irritating to hands and are effective in the absence of a sink. Hands should be washed with soap and water for at least 20 seconds when visibly soiled, before eating, and after using the restroom. Impact to operations. Healthcare organizations that encounter severe shortages and have exhausted supply chain access to efficacious products may consider local production of formulations. These locally produced products are intended for routine healthcare personnel. Hand cleaning must not contain active ingredients other than those specified in the Food and Drug Administration guidance, and should not take the place of other regulated skin antiseptics, for example, surgical hand rub. To avoid contamination with spore-forming organisms, World Health Organization formulations require a 72-hour post-production quarantine. Benzalkonium chloride, along with both ethanol and isopropanol, is deemed eligible by Food and Drug Administration external icon for use in the formulation of healthcare personnel hand rubs. However, available evidence indicates benzalkonium chloride has less reliable activity against certain bacteria and viruses than either of the alcohols. The hand sanitizer formulas have final concentrations of 80% ethanol or 75% isopropyl alcohol concentrations. A final concentration of 80% ethanol or 75% isopropyl alcohol are aligned with World Health Organization. World Health Organization formulations evaluated internationally, and are recommended by World Health Organization. For use in response to an emerging viral pathogen, including viruses that are genetically related to, and with similar physical properties as, the SARS-CoV-2. Personal protective equipment. What testing and standards should I consider when looking for Centers for Disease Control recommended protective clothing? Gowns. Centers for Disease Control's guidance for considerations for selecting protective clothing used in healthcare for protection against microorganisms in blood and body fluids outlines the scientific evidence and information on national and international standards, test methods, and specifications for fluid-resistant and impermeable gowns and coveralls used in healthcare. As with any type of personal protective equipment, the key to proper selection and use of protective clothing is to understand the hazards and the risk of exposure. Some of the factors important to assessing the risk of exposure in health facilities include source, modes of transmission, pressures and types of contact, and duration and type of tasks to be performed by the user of the personal protective equipment. For gowns, it is important to have sufficient overlap of the fabric so that it wraps around the body to cover the back, ensuring that if the wearer squats or sits down, the gown still protects the back area of the body. What type of gown is recommended for patients with suspected or confirmed COVID-19? Non-sterile, disposable patient isolation gowns, which are used for routine patient care in healthcare settings, are appropriate for use by patients with suspected or confirmed COVID-19. What types of gowns are available for healthcare personnel to protect from COVID-19? While the transmissibility of COVID-19 is not fully understood, gowns are available that protect against microorganisms. The choice of gown should be made based on the level of risk of contamination. Certain areas of surgical and isolation gowns are defined as critical zones where direct contact with blood, body fluids, and/or other potentially infectious materials is most likely to occur. If there is a medium to high risk of contamination and need for a large critical zone, isolation gowns that claim moderate to high barrier protection can be used. For healthcare activities with low, medium, or high risk of contamination, surgical gowns can be used. These gowns are intended to be worn by healthcare personnel during surgical procedures. If the risk of bodily fluid exposure is low or minimal, Gowns that claim minimal or low levels of barrier protection can be used. These gowns should not be worn during surgical or invasive procedures, or for medium to high-risk contamination patient care activities. What is the difference between gowns and coveralls? Centers for Disease Control's guidance for considerations for selecting protective clothing used in healthcare for protection against microorganisms in blood and body fluids provides additional comparisons between gowns and coveralls. Gowns are easier to put on and, in particular, to take off. They are generally more familiar to healthcare workers and hence more likely to be used and removed correctly. These factors also facilitate training in their correct use. Coveralls typically provide 360-degree protection because they are designed to cover the whole body, including the back and lower legs, and sometimes the head and feet as well. Surgical/isolation gowns do not provide continuous whole-body protection. For example, they have possible openings in the back, and typically provide coverage to the mid-calf only. The level of heat stress generated due to the added layer of clothing is also expected to be less for gowns when compared to coveralls due to several factors, such as the openings and the design of gowns and total area covered by the fabric. How do I put on, don, and take off, doff, my gown? Check to see if your facility has guidance on how to don and doff personal protective equipment. The procedure to don and doff should be tailored to the specific type of personal protective equipment that you have available at your facility. If your facility does not have specific guidance, the Centers for Disease Control has recommended sequences for donning and doffing of personal protective equipment. PDF icon. It is important for healthcare providers to perform hand hygiene before and after removing personal protective equipment. Hand hygiene should be performed by using alcohol-based hand sanitizer that contains 60 to 95% alcohol or washing hands with soap and water for at least 20 seconds. If hands are visibly soiled, soap and water should be used before returning to alcohol-based hand sanitizer. Gloves. What type of glove is recommended to care for suspected or confirmed COVID-19 patients in healthcare settings? Non-sterile disposable patient examination gloves, which are used for routine patient care in healthcare settings, are appropriate for the care of patients with suspected or confirmed COVID-19. What standards should be considered when choosing gloves? The American Society for Testing and Materials, ASTM, external icon has developed standards for patient examination gloves. Standard specifications for nitrile gloves, natural rubber gloves, and polychloroprene gloves indicate higher minimum tensile strength and elongation requirements compared to vinyl gloves. The American Society for Testing and Materials has developed standards for patient examination gloves. Length requirements for patient exam gloves must be a minimum of 220 mm to 230 mm depending on glove size and material type. Respirators. What is a respirator? A respirator is a personal protective device that is worn on the face or head and covers at least the nose and mouth. A respirator is used to reduce the wearer's risk of inhaling hazardous airborne particles, including infectious agents, gases or vapors. Respirators, including those intended for use in healthcare settings, are certified by the Centers for Disease Control and the National Institute for Occupational Safety and Health. Hat is an N95 filtering facepiece respirator, FFR. An N95 filtering facepiece respirator is a type of respirator which removes particles from the air that are breathed through it. These respirators filter out at least 95% of very small, 0.3 micron, particles. N95 filtering facepiece respirators are capable of filtering out all types of particles, including bacteria and viruses. Can a respirator with an exhalation valve be used as source control? Respirators with exhalation valves protect the wearer from SARS-CoV-2, the virus that causes COVID-19, but may not prevent the virus spreading from the wearer to others, that is, they may not be effective for source control. until data are available to describe how effective respirators with exhalation valves are in preventing the spread of SARS-CoV-2 from the wearer to others. 1. Wear a respirator without an exhalation valve when both source control and respiratory protection are required. 2. If only a respirator with an exhalation valve is available and source control is needed, cover the exhalation valve with a surgical mask, procedure mask, or a cloth face covering that does not interfere with the respirator fit. What makes N95 respirators different from face masks, sometimes called a surgical mask? Understanding the difference between surgical masks and N95 respirators. PDF icon. N95 respirators reduce the wearer's exposure to airborne particles, from small particle aerosols to large droplets. N95 respirators are tight-fitting respirators that filter out at least 95% of particles in the air, including large and small particles. When properly fitted and worn, minimal leakage occurs around edges of the respirator when the user inhales. This means almost all of the air is directed through the filter media. Face masks are loose-fitting and provide only barrier protection against droplets, including large respiratory particles. No fit testing or seal check is necessary with face masks. Most face masks do not effectively filter small particles from the air and do not prevent leakage around the edge of the mask when the user inhales. The role of face masks is for patient source control, to prevent contamination of the surrounding area when a person coughs or sneezes. Patients with confirmed or suspected COVID-19 should wear a face mask until they are isolated in a hospital or at home. The patient does not need to wear a face mask while isolated. Respiratory hygiene, cough etiquette in healthcare settings. To prevent the transmission of all respiratory infections in healthcare settings, including influenza, the following infection control measures should be implemented at the first point of contact with a potentially infected person. 1. Visual alerts. Post visual alerts, in appropriate languages, at the entrance to outpatient facilities, for example, emergency departments, physician offices, outpatient clinics, instructing patients and persons who accompany them, for example, family, friends, to inform healthcare personnel of symptoms of a respiratory infection when they first register for care and to practice respiratory hygiene, cough etiquette. 2. Respiratory hygiene, cough etiquette. The following measures to contain respiratory secretions are recommended for all individuals with signs and symptoms of a respiratory infection. Cover your mouth and nose with a tissue when coughing or sneezing. Use in the nearest waste receptacle to dispose of the tissue after use. Perform hand hygiene, for example, hand washing with non-antimicrobial soap and water, alcohol-based hand rub, or antiseptic hand wash, after having contact with respiratory secretions and contaminated objects/materials. Healthcare facilities should ensure the availability of materials for adhering to respiratory hygiene, cough etiquette in waiting areas for patients and visitors. Provide tissues and no-touch receptacles for used tissue disposal. Provide conveniently located dispensers of alcohol-based hand rub, where sinks are available. Ensure that supplies for hand washing, that is, soap, disposable towels, are consistently available. 3. Masking and separation of persons with respiratory symptoms. During periods of increased respiratory infection activity in the community, for example, when there is increased absenteeism in schools and work settings and increased medical office visits by persons complaining of respiratory illness, offer masks to persons who are coughing. Either procedure masks, that is, with ear loops, or surgical masks, that is, with ties, may be used to contain respiratory secretions. Respirators such as N95 or above are not necessary for this purpose. When space and chair availability permit, encourage coughing persons to sit at least 3 feet away from others in common waiting areas. Some facilities may find it logistically easier to institute this recommendation year-round. On this slide the wrong and right examples of cough etiquette are presented. 4. Droplet precautions. Advise healthcare personnel to observe droplet precautions, that is, wearing a surgical or procedure mask for close contact, in addition to standard precautions, when examining a patient with symptoms of a respiratory infection, particularly if fever is present. These precautions should be maintained until it is determined that the cause of symptoms is not an infectious agent that requires droplet precautions. Sharps safety. For designing, implementing and evaluating a sharps injury prevention program. Introduction. Occupational exposure to bloodborne pathogens from needle sticks and other sharps injuries is a serious problem, but it is often preventable. The Centers for Disease Control and Prevention, CDC, estimates that each year 385,000 needle sticks and other sharps-related injuries are sustained by hospital-based healthcare personnel. Similar injuries occur in other healthcare settings, such as nursing homes, clinics, emergency care services, and private homes. Sharps injuries are primarily associated with occupational transmission of hepatitis B virus, HBV, hepatitis C virus, HCV, and human immunodeficiency virus, HIV, but they have implicated in the transmission of more than 20 other pathogens. Overview of the program plan. An effective sharps injury prevention program includes several components that must work in concert to prevent healthcare personnel from suffering needle sticks and other sharps-related injuries. This program plan is designed to be integrated into existing performance improvement, infection control, and safety programs. It is based on a model of continuous quality improvement, an approach that successful healthcare organizations are increasingly adopting. We can describe this model in a variety of terms, but the underlying concept is that of a systematic, organization-wide approach for continually improving all processes performance improvement, involved in the delivery of quality products and services. The program plan also draws on concepts from the industrial hygiene profession, in which prevention interventions are prioritized based on a hierarchy of control strategies. The plan has two main components. 1. Organizational steps for developing and implementing a sharps injury prevention program. These include a series of administrative and organizational activities, beginning with the creation of a multidisciplinary working team. The steps are consistent with other continuous quality improvement models in that they call for conducting a baseline assessment and setting priorities for development of an action plan. An ongoing process of review evaluates the plan's effectiveness and modifies the plan as needed. 2. Operational processes. These activities form the backbone of the sharps injury prevention program. They include creating a culture of safety, reporting injuries, analyzing data, and selecting and evaluating devices. Eyes damage. Causes. Aerosols and splashes can transmit infection. Sharp debris ejected from the mouth when using the handpiece of an air turbine, an ultrasonic calculus remover, can cause eye injury. Eye injuries in patients with sharp objects, especially in the supine position. Safe injection practices. What are safe injection practices? Safe injection practices are intended to prevent transmission of infectious diseases between one patient and another, or between a patient and dental health care personnel. DHCP, during preparation and injection of medications. Dental health care personnel most frequently handle parenteral medications when administering local anesthesia, during which needles and anesthetic cartridges are used for one patient only, and the dental cartridge syringe is cleaned and heat sterilized between patients. Other safe practices apply to use of injected medications and for fluids, such as for patients undergoing conscious sedation. A safe injection does not harm the recipient and does not expose dental health care personnel to any avoidable risks. What are the Centers for Disease Control and Prevention's, CDC's, safe injection practice recommendations for dentistry? Prepare injections using aseptic technique in a clean area. Disinfect the rubber septum on a medication vial with alcohol before piercing. Do not use needles or syringes for more than one patient. This includes manufactured pre-filled syringes and other devices such as insulin pens. Medication containers, single and multi-dose vials, ampules, and bags, are entered with a new needle and new syringe, even when withdrawing additional doses for the same patient. Use single-dose vials for parenteral medications when possible. Do not use single-dose, single-use, medication vials, ampules, and bags or bottles of intravenous solution for more than one patient. Do not combine the leftover contents of single-use vials for later use. The following apply if multi-dose vials are used. Dedicate multi-dose vials to a single patient whenever possible. If multi-dose vials will be used for more than one patient, they should be restricted to a centralized medication area and should not enter the immediate patient treatment area, for example, dental operatory, to prevent inadvertent contamination. If a multi-dose vial enters the immediate patient treatment area, it should be dedicated for single patient use and discarded immediately after use. Date multi-dose vials when first opened and discard within 28 days, unless the manufacturer specifies a different date. Do not use fluid infusion or administration sets, for example, 4 bags, tubings, connections, for more than one patient. Sterilization and disinfection of patient care items and devices. Cleaning is the necessary first step of any disinfection process. Cleaning removes organic matter, salts, and visible soils, all of which interfere with microbial inactivation. The physical action of scrubbing with detergents and surfactants and rinsing with water removes substantial numbers of microorganisms. If a surface is not clean first, the success of the disinfection process can be compromised. Removal of all visible blood and inorganic and organic matter can be as critical as the germicidal activity of the disinfecting agent. When the surface cannot be cleaned adequately, it should be protected with barriers. Disinfection destroys most pathogenic and other microorganisms by physical or chemical means. In contrast, sterilization destroys all microorganisms, including substantial numbers of resistant bacterial spores, by heat, steam autoclave, dry heat, and unsaturated chemical vapor, or liquid chemical sterilants. Disinfection does not ensure the degree of safety associated with sterilization processes. Environmental surfaces can be divided into clinical contact surfaces and housekeeping surfaces. Clinical contact surfaces can be directly contaminated from patient materials either by direct spray or spatter generated during dental procedures or by contact with gloved hands of dental health care personnel. These surfaces can subsequently contaminate other instruments, devices, hands, or gloves. Housekeeping surfaces, for example, walls, floors, sinks, are not directly touched during dental treatment and carry the lowest risk of disease transmission. There are 3 levels of disinfection: high, intermediate, and low. High-level disinfectants, such as glutaraldehyde, are used as chemical sterilants and should never be used on environmental surfaces. Intermediate-level disinfectants are registered with the Environmental Protection Agency, EPA, and have a tuberculocidal claim, and low-level disinfectant are EPA registered without a tuberculocidal claim, that is, hepatitis B virus and HIV label claims. Cross-infection in dentistry. Categories of patient care items. According to the Centers for Disease Control, dental instruments are classified into 3 categories depending on the risk of transmitting infection. The classifications of critical items, semi-critical items and non-critical items are based on intended use and the potential risk of disease transmission. Critical instruments are those used to penetrate soft tissue or bone, or enter into or contact the bloodstream or other normally sterile tissue. They should be sterilized after each use. Sterilization is achieved by steam under pressure, autoclaving, dry heat, or heat/chemical vapor. Critical instruments include forceps, scalpels, bone chisels, scalers and surgical burrs. Semi-critical instruments are those that do not penetrate soft tissues or bone but contact mucous membranes or non-intact skin, such as mirrors, reusable impression trays and amalgam condensers. These devices also should be sterilized after each use. In some cases, however, sterilization is not feasible and, therefore, high-level disinfection is appropriate. Special notes for semi-critical products, dental handpieces. Follow the manufacturer's instructions for the safe handling of dental handpieces and accessories, for example, low-speed motor, reusable wear brackets. Clean and heat sterilize prior to use prior to patient handling. Do not subject the handpiece to a high-level disinfectant or simply wipe the surface with a low-level disinfectant. Special notes for semi-critical products, digital sensors. Follow manufacturer's instructions for safe recycling of digital radiography equipment. Ideally, barrier protection should be used followed by cleaning and thermal sterilization or high-level disinfection between patients. If the subject does not tolerate these procedures, at least a barrier protection should be used, followed by cleaning and disinfection with an intermediate-level disinfectant between patients. Non-critical items are those that come into contact only with intact skin, such as external components of X-ray heads, blood pressure cuffs and pulse oximeters. Such devices have a relatively low risk of transmitting infection, and, therefore, may be reprocessed between patients by intermediate-level or low-level disinfection. Single-use, disposable, devices. Intended for use on one patient during a single procedure. Usually not heat-tolerant. Cannot be reliably cleaned. Do not reprocess. Examples: syringe needles, prophylaxis cups, and plastic orthodontic brackets. Sterilization. There are many stages for instrument sterilization. They are pre-soaking, cleaning, corrosion control and lubrication, packaging, sterilization, handling sterile instruments, storage, distribution. Agents used in sterilization: physical agents, 1. Sunlight, 2. Drying, 3. Dry heat, flaming, incineration, hot air, 4. Moist heat, pasteurization, boiling, steam under pressure, steam under normal pressure, 5. Filtration, candles, asbestos pads, membranes, 6. Radiation, 7. Ultrasonic and sonic vibrations. Chemical agents. 1. Alcohols, ethyl, isopropyl, trichlorobutanol. 2. Aldehydes, formaldehyde, glutaraldehyde. 3. Dyes. 4. Halogens. 5. Phenols. 6. Surface active agents. 7. Metallic salts. Gases, ethylene oxide, formaldehyde, beta-propiolactone. Instrument processing. Follow manufacturer's instructions for reprocessing, that is, cleaning, packaging, disinfecting, sterilizing, reusable dental instruments and equipment. Maintain manufacturer's instructions, ideally, in or near the reprocessing area. Use Food and Drug Administration cleared devices and supplies for cleaning, packaging, and heat sterilization. Should be assigned to dental health care personnel with training in the required reprocessing steps. Instrument processing area. Use a designated processing area to control quality and ensure safety. Divide processing area into work areas. Receiving, decontamination, and cleaning. Preparation and packaging. Sterilization. Storage. Devices and instruments should flow from high contamination areas to clean and sterile areas. Transport of instruments to the sterilization area. Most dental offices have a designated area for instrument reprocessing that is separate from the dental treatment room. This is ideal, since cleaning, sterilizing and storing instruments in the same room where the delivery of patient care is provided increases the risk of cross-contamination. The removal and disposal of single-use sharps such as needles, blades, orthodontic wires and glass must be done at the point of use, typically in the dental treatment room. Some instruments and materials are single-use only. Single-use items should be segregated in the operatory, and those that are sharp or otherwise pose a risk of injury must be discarded into a sharps container. Items without risk, such as a saliva injector, can be thrown into the trash. Finally, the tray or cassette of reusable instruments is taken to the cleaning and sterilization area for processing. Transport of instruments to the sterilization area. To prevent accidental injury with the contaminated instruments, special handling should be used to transport the instruments to the cleaning and sterilization area. The Centers for Disease Control and Prevention, CDC, states that contaminated instruments should be handled carefully to prevent exposure to sharp instruments that can cause percutaneous injury. Instruments should be placed in an appropriate container at the point of use to prevent percutaneous injuries during transport to the instrument processing area. In addition, the Occupational Safety and Health Administration says, the person handling the instruments through removal, cleaning, packaging and sterilization needs to use heavy-duty gloves to help prevent injury with sharp contaminated instruments. Although heavy-duty gloves, utility gloves, may feel more awkward than examination gloves, they provide extra protection while handling instruments during the cleaning, rinsing, drying, packaging and sorting procedures that take place during instrument reprocessing. The fine tactile sensitivity needed during dental procedures is not necessary during instrument cleaning and sterilization, therefore, heavy-duty gloves pose no problem in this regard. Additionally, nitro-utility gloves are available in a variety of sizes, allowing a more secure fit. Cleaning. Cleaning should always occur before disinfection or sterilization. Presence of soil can compromise the disinfection or sterilization process. Automated or manual. Minimize exposure potential. Use carrying containers to transport contaminated instruments. Wear personal protective equipment, for example, heavy-duty utility gloves, mask, protective eyewear and clothing. Pre-sterilization cleaning. Provides for the removal of protein, fat, mechanical contamination and drug residues from the surface of products. Cleaning is carried out manually or mechanically using detergents. The detergent solution Biolit or solutions containing hydrogen peroxide with synthetic detergents, SD, Progress, Marichka, Astra, Ina, Lodos, Lodos Automat, the last two with and without a corrosion inhibitor, etc. To reduce the corrosion of metal tools, it is advisable to use a solution of detergent Biolit or detergent solutions containing hydrogen peroxide with SMS Lodos or Lodos Automat and a corrosion inhibitor sodium oleate. Pre-sterilization cleaning. If manual cleaning is not done immediately, soak the tools until they are ready to clean to prevent debris from drying out on the tools. Wear strong work gloves, mask, goggles and protective clothing. First stage, rinse instruments under running water to remove residual disinfectant. Second stage, immerse the instruments in the washing solution for 15 minutes, provided that the products are completely immersed. The cleaning solution is prepared by the personnel of the central sterilization room according to one of the methods, see table. The names of components, the content of components and the preparation of detergent, are presented in this table. Preparation of washing solution. Stage 3, each instrument is washed in a washing solution with a brush or a cotton gauze swab for 0.5 minutes. The temperature of the solution is not maintained during washing. Stage 4, rinse the instruments under running water to free them from the detergent. After applying the powder Biolit washing lasts 3 minutes, Progress, 5 minutes, other solutions detergents, 10 minutes. Quality control of pre-sterilization processing of instruments is carried out. Stage 5, the instruments are washed in distilled water to remove salts from tap water, 0.5 minutes for each instrument. Stage 6, dry the instruments in a dry heat cabinet and temperature 85 degrees Celsius until the moisture completely disappears. There are stages of dry cleaning. Cleaning mode. Preliminary solution temperature. Exposure time. Equipment are presented in this slide. Dry cleaning of stainless steel tools. Note: 1 star for stainless steel scalpels. 2 stars for tools with an oxide film. 3 stars for tools with severe corrosion damage. It is recommended to additionally clean the damaged areas with a brush or cotton gauze swab. Cleaning. Using mechanical means of instrument cleaning rather than hand scrubbing should minimize handling of instruments. If procedures are used whereby hand scrubbing is necessary, heavy-duty, utility, gloves, mask, eyewear and gown should always be worn while cleaning. Minimize the risk of puncture injury by scrubbing only one instrument at a time while holding it low in the sink. Use of a system utilizing locked cassettes eliminates the need to sort, handle and hand scrub individual instruments, reducing the risk of infection from contaminated instruments, and results in savings of, on average, 5 minutes during instrument reprocessing, as well as fewer damaged instruments, since the instruments are locked in position during reprocessing. As with any standardized procedure, a standardized instrument reprocessing protocol also results in easy staff training and cross-training. In general, 3 classifications of mechanical cleaning devices are available for the dental office. They are: the ultrasonic cleaner, instrument washer, disinfector. Automatic cleaning, ultrasonic cleaning devices. An ultrasonic cleaner uses sound waves that are outside the human hearing range to form oscillating bubbles, a process called cavitation. These bubbles act on debris to remove it from the instruments. Some manufacturers also use intermittent or sweeping sound waves to help improve the device's cleaning ability and to decrease the potential for hot spots in the ultrasonic bath. Specialized detergent formulations are available for the solutions in ultrasonic machines. When selecting a cleaning agent to use in the ultrasonic cleaner, always consider the effect on materials and instruments. Household products are inappropriate because they cause pitting, corrosion, rust or other damage to instruments, and potentially to the ultrasonic chamber. Therefore, it is best to follow the manufacturer's instructions, thereby choosing a solution that is compatible with the unit and the instruments. The procedure for cleaning the instruments in the ultrasonic cleaner is as follows. Suspend instruments in the ultrasonic bath using a rack or basket fitted to the unit. Do not lay instruments directly on the bottom of the ultrasonic cleaner, as this can interfere with cleaning and cause damage to instruments and the ultrasonic machine. Avoid overloading the ultrasonic device, since that could inhibit its cleaning ability. It is important to follow the manufacturer's instructions for the ultrasonic cleaning cycle. In general, the timer is activated for 3 to 6 minutes for loose instruments and 10 to 20 minutes for instrument cassettes, and the timing is adjusted as necessary. While the ultrasonic device is running, the lid or cover should be kept on to reduce the release of aerosol and spatter into the area from the ultrasonic cleaner. Routinely replacing the cleaning solution in the ultrasonic machine is important, and is necessary at least once a day, more often with heavy usage. Instrument washers. Instrument washers use high-velocity hot water and a detergent to clean instruments. Widely used for decades in hospitals and large facilities as part of the central sterilization process, these devices have recently become available for the dental office. These devices require personnel to either place instruments in a basket or to use instrument cassettes during the cleaning and drying cycles. Instrument washers for dental offices come in 2 different designs. One is a countertop model. This type does not require professional installation. The other type is built-in and resembles a kitchen dishwasher. It functions much the same as the countertop model, but it has a larger capacity and requires professional installation. Some models have the ability to dry the instruments after washing, some do not. Instrument washers/thermal disinfectors. These devices may look like the instrument washers described above. However, there is one important difference. The high temperature of the water and chemical additives in these devices cleans and disinfects the instruments. The significance of this lies in how personnel can handle the instruments after the process. Upon removal from a thermal disinfector, instruments can be more safely handled, and if the dental healthcare professional were to sustain a puncture injury, it would not require the follow-up that a contaminated exposure requires. All instrument washers and thermal disinfectors use either a detergent or a water softening agent. It is possible for the pH of some of these chemicals to be incompatible with certain metals and dental instruments. For specific recommendations, the manufacturer of the dental instruments and the manufacturer of the instrument washer should be consulted. Instrument washers and thermal disinfectors are approved medical devices that have been rigorously tested to meet Food and Drug Administration requirements for safety and efficacy of medical devices. Household dishwashers are not appropriate for use in a dental office. Instrument examination and care. Cleaning instruments provides a good opportunity to examine, replace or remove damaged instruments. Lubricate items such as handpieces and otherwise prepare instruments for sterilization. Instruments must be dry before packaging. If drying was not part of the cleaning process, time must be taken to dry the instruments completely. High-quality metal dental cassettes specially designed to withstand high temperatures are preferred for use with steam and chemical vapor sterilizers. Most sterilizers on the market today offer a cassette track, which helps to prevent overloading in the sterilizer, thereby reducing the risk of ineffective sterilization and ultimately of infection and cross-infection. Washing machines. Optimal and economically justified is pre-sterilization cleaning, combining in one stage pre-sterilization cleaning and disinfection. To do this, there is a fairly large selection of disinfectants and special equipment, washing machines and thermal disinfection, washing machines. Quality control of pre-sterilization processing of instruments. Quality control of pre-sterilization processing of instruments is carried out by the method of sampling. Benzidine, imidacloprid, or orthodiludine tests have previously been performed for traces of occult blood that may remain due to insufficient purification. Currently, an azopyramine test is performed, which is 10 times higher than the sensitivity of the imidacloprid test and is not inferior in sensitivity to the benzidine test. Detection of residues of alkaline components of detergent is carried out by means of phenolphthalein test. Presence of oil. Syringes applied to oil injections are subject to control of presence of oil, is defined by means of test with Sudan 3. Azopyramine test. Preparation of initial and working solutions of azopyram. 1. Order an initial solution of azopyram, imidacloprid 10 grams, hydrochloric aniline 0.15 grams, 95 degrees ethyl alcohol 100 grams, at the pharmacy. 2. Store these solutions in a closed vial at +4 degrees Celsius, in a refrigerator, for 2 months, in a dark place at room temperature for 1 month. 3. Moderate yellow color during storage without precipitation does not indicate its unsuitability. 4. Immediately before checking the quality of pre-sterilization cleaning of products, prepare a working solution. Mix azopyram and 3% hydrogen peroxide solution in a ratio of 1:1. 5. If necessary, check the suitability of the working solution of azopyram. Apply 2 to 3 drops of the solution on the blood spot. If after 1 minute there is a purple color, alternating with lilac, the reagent is suitable for use. If the color does not appear within 1 minute, the reagent is not suitable for use. Methods of azopyramine test. Treat the subject with azopyram working solution, wipe with a swab dipped in the reagent, or apply a few drops of reagent with a pipette. To check the quality of needle cleaning, type the reagent into a clean, no trace of corrosion, syringe and, gradually changing the needles, pass the solution through them, squeezing 3 to 4 drops on a napkin. To check the quality of cleaning the syringe with a pipette, add a few drops of reagent and after 30 seconds, pour it on a gauze napkin or cotton swab. The amount of reagent required to inspect other hollow articles depends on their size. Pollution indication. 1. Azopurim detects the presence of hemoglobin and peroxidases of plant origin, plant residues, detergents from bleach, rust and acids. 2. In the presence of traces of blood not later than in 1 minute after contact with the polluted site, there is a violet coloring which then within several seconds turns to pink lilac or brownish. 3. Brownish color is observed in the presence of rust or oxidants containing chlorine on the inspected objects. In other cases, the color is pink lilac. 4. The inspected products must be at room temperature, not above 25 degrees Celsius. Hot items are not subject to inspection. 5. Do not store the solution in bright light or high temperature. 6. The working solution, azopurim with hydrogen peroxide, must be used within 1 to 2 hours. At an air temperature above 25 degrees Celsius, the working solution is used within 30 to 40 minutes. 7. After the test, regardless of the results, remove the remnants of azopurim from the inspected items, wash them with water and again carry out pre-sterilization cleaning of these products. Precautions in using azopurim. 1. Azopurim should be stored in a tightly closed container separate from food, drugs, disinfectants, concentrated acids and alkalis. 2. If azopurim comes into contact with the skin or mucous membranes, remove it immediately with a tissue and rinse the area with running water. 3. Azopurim burns, so its contact with open flames is unacceptable. Imidopyridine test. Preparation of imidopyridine reagent. To 2 ml of 5% alcohol solution of imidopyridine add 2 ml of 30% acetic acid and 2 ml of 3% hydrogen peroxide. The reagent is prepared before use. A 5% alcohol solution of imidopyridine is prepared on 95 degrees ethyl alcohol. This solution can be stored in a vial with a ground stopper in the refrigerator for 1 month. A 30% solution of acetic acid and a 3% solution of hydrogen peroxide are prepared in distilled water. Conducting method. Pipette the reagent onto the instruments and wait up to 2 minutes. In the presence of blood residues, a blue-green color appears. Color change after 2 minutes is not taken into account. In case of a positive reaction to occult blood, it is necessary to repeat the second, third and fourth stages of pre-sterilization cleaning. Phenolphthalein test. Reagent preparation. For setting the sample, a 1% alcoholic solution of phenolphthalein is used, consisting of 60 grams of alcohol, 40 grams of distilled water and 1 gram of phenolphthalein. Alcoholic solution of phenolphthalein can be stored in a bottle with a ground-in stopper in the refrigerator for 1 month. Methodology. The solution is applied with a pipette to cotton wool and the processed instruments are wiped. If there are residues of synthetic detergent, a pink color appears within 30 seconds. In this case, it is necessary to repeat the fourth stage of cleaning, that is, the entire batch of products is subjected to rinsing in running water, and then in distilled water. Sudan 3 test. The Sudan 3 test is used to determine fatty contamination in syringes and other products associated with this contamination. Reagent preparation. In 70 ml of 95O ethyl alcohol heated to 680 degrees Celsius, in a water bath, 0.2 grams of crushed Sudan 3 paints and methylene blue are dissolved. Then add 10 ml of 20 to 25% ammonia solution and 20 ml of distilled water. This solution can be stored in a tightly closed bottle, in the refrigerator, for 6 months. Methodology. When checking the quality of cleaning the syringe from fatty contaminants, 3 to 5 ml of the reagent is introduced into it and the entire inner surface is moistened. After 10 seconds the paint is washed off with a large stream of water. Yellow spots and smudges indicate the presence of grease. Instrumental examination and care. Cleaning of tools provides a good opportunity to inspect, replace or remove damaged tools, lubricate items such as pens, and otherwise prepare instruments for sterilization. Instruments must be dried before packaging. If drying was not part of the cleaning process, it will take a time for them to dry completely. High-quality metal dental cassettes specifically designed to withstand high temperatures are preferred for use with steam and chemical steam sterilizers. Most sterilizers on the market today offer a cassette track that helps prevent overloading the sterilizer, thereby reducing the risk of ineffective sterilization and ultimately infection and cross-contamination. Preparation and packaging. Wrap, package, or place instruments in containers before heat sterilization. Instruments should be thoroughly dry before they are packaged, wrapped, or otherwise contained. Follow manufacturer's instructions. For example, open hinged instruments, disassemble instruments if required, and ensure that packaging materials are compatible with the method of heat sterilization being used. Place a chemical indicator inside each package. If the internal chemical indicator cannot be seen from the outside, place another indicator on the outside of the package. Label the package with the following: sterilizer number, cycle or load number, date of sterilization, expiration date, if applicable. Packaging. Packaging used for instruments and cassettes prior to sterilization includes wrap, paper pouches, plastic pouches, combination paper/plastic pouches and nylon tubing. Sterilization packaging is specifically designed to allow penetration of heat, steam or vapor and then to seal the sterilized instruments inside the package for sterile storage. After sterilization, instruments should remain in packages until use. Different materials are appropriate for different types of sterilizers. Unless otherwise specified, all packaging is single-use only. Using tape to reseal previously used packaging material may inhibit its ability to continue to function as intended by the manufacturer. Sterilization rolls Eurosterile. Packing machine, MOCOM, by Italy. Pulse heat sealing device. Seamless tube sterilization film, Defend Healthcare Corporation, by USA, are presented on the current slide. Sterilization. From Latin. Sterilize, barren. This is the destruction of all microorganisms and their spores using physical and chemical factors. It is carried out to prevent the spread of a number of infectious diseases, pathogens of which are transmitted through blood and biological fluids. Parameters such as time, pressure, and temperature vary according to the type of sterilizer, materials being sterilized and individual models within sterilizer brands. The first step in determining the settings for the sterilizer is to refer to the manufacturer's instructions. Sterilizers are medical devices, requiring clearance by the Food and Drug Administration before manufacturers may offer them for sale. The Food and Drug Administration requires rigorous testing to ensure an adequate margin of safety in each cycle type described in the instructions. Failing to follow the instructions of the manufacturer is ill-advised, since it may result in inadequate sterilization of the instruments or devices in the sterilizer. It is never appropriate to use a household device, such as a toaster oven, for sterilization of dental instruments, devices, or equipment. Sterilization methods. Thermal, steam and air, dry heat. Chemical, gas or chemical solutions, sterilants. Plasma, hydrogen peroxide plasma. Radiation sterilization, used in an industrial version. Membrane filter method. Used to obtain a small amount of sterile solutions, the quality of which can deteriorate sharply under the action of other sterilization methods, bacteriophage, selective culture media, antibiotics. Method type and method. Physical, thermal. Steam, air, infrared, glass purlin. Chemical. Gas, plasma, liquid. Radiation. Radiation sterilization method gamma rays. Mechanical. Membrane filter method. And sterilizing agent. Are presented on the current slide. Thermal sterilization. Roasting and boiling. Firing is currently not used to sterilize instruments. The method can be used at home, as well as in tundra, field, conditions when it is impossible to use others. Firing metal tools is carried out with an open flame. Usually a tool is placed on a metal tray, a small amount of ethyl alcohol is poured and set on fire. For a long time, boiling was the main method of sterilizing instruments, but recently it has been rarely used, since this method reaches a temperature of only 100 degrees Celsius, which is not enough to destroy spore-bearing bacteria. The instruments are boiled in special electric sterilizers of various capacities. Opened instruments, disassembled syringes, are placed on a grid and immersed in distilled water. Sodium bicarbonate may be added, up to 2% solution. The usual sterilization time is 30 minutes from boiling. Thermal sterilization. Steam method. It is the most effective and most commonly used sterilization method in dental practices. This is due to the fact that the steam under pressure in the autoclave allows you to get rid of all types of microbes and their spores. Autoclave instruments are sterilized at 121 degrees Celsius for 15 minutes and 15 pounds of pressure, 14.696 psi equals 0.10133 megapascals equals 1.0133 bar equals 1 atmosphere equals 760 millimeters. The steam method can be used to sterilize linen, dressing gowns, sheets, towels, dressings, rubber products, glass, corrosion-resistant metals. Sterilization is carried out in sterilization boxes without filters, in sterilization boxes with a filter, see figure, in double soft packaging made of coarse calico or in parchment packaging, non-impregnated sack paper, moisture-resistant sack paper, paper for packaging products on machine Z, high-resistant packaging paper, double-layer crepe paper. The shelf life of sterile material in sterilization boxes, BICs, with a filter is no more than 20 days, in sterilization boxes without filters and in other packages, double packaging made of coarse calico, moisture-resistant bag paper, craft paper, untreated bag paper, parchment, no less 3 days. Steam autoclaves are the most commonly used type of heat sterilizer in dental practices. Two types of processes employ steam under pressure. The difference between the two is the manner in which the machine evacuates the air from the sterilization chamber and then introduces the steam. Gravity displacement sterilizers rely on the forces of gravity to force air out of the chamber through air escape vents. The steam entering the chamber from the water reservoir displaces the air as it leaves the chamber. The combination of pressurization of the chamber, steam and a high temperature for a prolonged period has the ability to kill virtually all microorganisms. The sterilization cycle time decreases as the temperature is increased. It is important to use cycle times and temperatures described in the owner's manual, and never to interrupt the sterilization cycle to remove or add items, or for any other reason. Interruption of the cycle will result in instruments that are not sterile and therefore not safe for use on patients. After the sterilization cycle, the sterilizer must depressurize and the packs remain in the sterilizer for drying. The drying phase may take anywhere from 20 to 45 minutes. The unit must only be opened after completion of the drying cycle. Upon removal from the sterilizer, sterile packs must be stored in a clean, dry area. Packs that become wet, torn, contaminated, or otherwise compromised require re-sterilization. Pre-vacuum autoclaves, also called Class B or Type B sterilizers, use a variety of technologies to remove air from the chamber before the steam enters, thus creating a vacuum. Most use a pulse vacuum to ensure elimination of air from the chamber. This is generally a more efficient means of pressurizing the chamber, therefore, the operator may notice some minor time saving in the startup of the pre-vacuum sterilizers. Most pre-vacuum sterilizers use a temperature of 132 degrees Celsius to 135 degrees Celsius for 3 to 10 minutes to achieve sterilization. This higher temperature may be unacceptable for some items, such as Teflon-coated instruments. Total time for pressurization, sterilization, venting and drying is generally considerably shorter than that for gravity sterilizers, about 45 minutes. Steam method. Advantages of autoclaves. 1. Autoclaving is the most rapid and effective method for sterilizing cloth surgical packs and towel packs. 2. Is dependable and economical. 3. Sterilization is verifiable. Disadvantages of autoclaves. 1. Items sensitive to the elevated temperature cannot be autoclaved. 2. Autoclaving tends to rust carbon steel instruments and burrs. 3. Instruments must be air-dried at completion of cycle. Autoclave sterilization modes. First mode. At 30 pounds per square inch, plus or minus 0.2, 20 minutes and a temperature of 132 plus or minus 2 degrees Celsius is recommended for glass products, corrosion-resistant metals, textile materials, rubber. Second mode. At 23 pounds per square inch, plus or minus 0.2, 45 minutes and a temperature of 120 plus or minus 2 degrees Celsius is used for rubber products, latex, certain polymer materials. High-density polyethylene, polyvinyl chloride plasticates. 2. Dry heat sterilization, convection and static air. Thermal sterilization, air method. Dry heat sterilization employs high temperatures for extended periods to achieve sterilization of instruments. Sterilization is carried out in special devices, dry heat sterilizers. Sterilization in a dry heat cabinet occurs by circulating hot air inside it. With dry heat sterilization, bacterial spores tolerate higher temperatures and longer than with wet heat sterilization. Therefore, heat-resistant glassware, powders, oils, etc. are sterilized for 1 hour at a temperature of 180 degrees Celsius. Sterilization in an autoclave and dry heat cabinet is currently the main, most reliable way to sterilize surgical instruments and glassware. The method of heat circulation in dry heat sterilizers is usually convection, which helps to ensure that the heat circulates throughout the sterilization chamber during the process. Mechanical convection is more effective. The sterilizer contains a fan or blower that continually circulates the heated air to maintain a uniform temperature throughout the chamber. Most commercially available dry heat sterilizers on the market today are of this type. The higher temperature of a dry heat sterilizer means that paper will scorch and plastic will melt. Specialized packaging material is available for dry heat sterilizers. Most handpieces will not tolerate the higher temperatures of a dry heat sterilizer. Mechanically driven handpieces that contain turbines and bearings are susceptible to damage at higher temperatures. The manufacturer's instructions should be checked for compatibility of instruments, devices, and materials with the unit, and the handpiece manufacturer's instructions should be followed for preparation of the handpiece prior to sterilization and for sterilization itself. Thermal sterilization. Glass purlin method. The principle of operation of the glass purlin sterilizer is based on bringing sterilizable surgical instruments into contact with small glass spheres at a temperature of 250 degrees Celsius. The sterilizer is designed for quick sterilization of all metal, without cavities, channels and locking parts, dental and other medical instruments and devices in an environment of glass balls heated to a temperature of 190 to 290 degrees Celsius with full immersion of small items in them, as well as working parts of larger items. In the figure, glass purlin sterilizers tau quartz 150 and 500 are presented. The instrument is sterilized within a very short time, no more than 20 seconds. Due to such a short period and the non-destructive effect of sterilization, glass purlin, balls on the instrument, there is practically no negative effect of high temperature. In just 5 seconds it sterilizes forceps, pliers, scalpel holders, probes, spatulas, chisels, diamonds, files, burrs, root elevators, dilators, contra-angle handpieces, needle holders, forceps, gingival scissors, etc. Thermal sterilization. Infrared method. The small-sized sterilizer is intended for sterilization of dental and microsurgical instruments made of metals in hospitals, clinics, hospitals and other medical and cosmetic institutions. Sterilization is carried out with a powerful short-term infrared thermal effect. 3. Unsaturated chemical steam sterilization is based on the use of a proprietary chemical that contains formaldehyde, alcohol and other inert ingredients instead of water to produce steam to aid sterilization. The use of this proprietary chemical also results in the steam being less humid and therefore less corrosive to sensitive instruments than water. During chemical vapor sterilization, a mixture of various chemicals such as alcohol, ketones, formaldehyde and water is heated under pressure to form a sterilization gas. A typical sterilization procedure requires 20 minutes at 132.2 degrees Celsius, 270 degrees Fahrenheit, at 20 pounds per square inch to complete. Chemical sterilization. Gas method. In world practice, there are two main methods. 1. Gas ethylene oxide. 2. Gas formaldehyde. Gas sterilization carried out in special sealed chambers. The sterilizing agent is usually formalin vapor, formaldehyde tablets are placed on the bottom of the chamber, or ethylene oxide. Instruments placed on the mesh are considered sterile after 6 to 48 hours, depending on the components of the gas mixture and the temperature in the chamber. A distinctive feature of the method is its minimal negative impact on the quality of the instrumentation, and therefore the method is used primarily for sterilization of optical, highly accurate and expensive instruments. When sterilizing food products, medicines and various devices, as well as in laboratory practice, the use of ethylene oxide has justified itself, which kills both vegetative cells and spores, but only acts if the materials to be sterilized contain a certain amount, 5 to 15%, water. Ethylene oxide is used in the form of a gas mixture, with N2 or CO2, in which its share is from 2 to 50%. The ethylene oxide method provides the most gentle sterilization temperature. Gas sterilization modes. 1. Ethylene oxide at a dose of 1000 ml per cubic decimeter under a gas pressure of 0.55 kg per square centimeter and a temperature of 18 degrees Celsius, 960 minutes, 16 hours. 2. Ethylene oxide at a temperature of 35 or 55 degrees Celsius. 3. A mixture of OB at a temperature of 18, 35 or 55 degrees Celsius. 4. Steam of a 40% solution of formaldehyde in ethyl alcohol at a dose of 150 mg per cubic decimeter at a temperature of 80 degrees Celsius, 180 minutes, 3 hours. 5. Steam of formaldehyde in ethyl alcohol at a temperature of 42, 45 or 65 degrees Celsius. 6. Steam of an aqueous solution of formaldehyde at a temperature of 70 degrees Celsius. Note: a mixture of ethylene oxide and metal bromide in a weight ratio of 1:2.5. Chemical sterilization. Plasma method allows you to create a biocidal environment based on an aqueous solution of hydrogen peroxide, as well as low-temperature plasma, ionized gas formed at low pressure. This is the most modern method of sterilization known today. It allows you to sterilize any medical device, from hollow instruments to cables, electrical appliances, to which in some cases it is not possible to apply any of the known methods of sterilization. In this method, after injection of a solution of hydrogen peroxide into the sterilization chamber, a source of electromagnetic radiation with a frequency of 13.56 MHz is turned on, under the influence of which one part of hydrogen peroxide molecules is simultaneously divided into two hydroxyl groups, oxygen-hydrogen, and the other part into one hydroperoxyl group, double oxygen-hydrogen, and one hydrogen atom, accompanied by the release of visible and ultraviolet radiation. The result is a biocidal medium consisting of molecules of hydrogen peroxide, free radicals and ultraviolet radiation. When plasma sterilization is required: 1. Implantable products. 2. Products with long channels. 3. Endoscopes and instruments. 4. Optics. 5. Tools for ophthalmology. 6. Tools for cardiac surgery. 7. Tools for microsurgery. 8. Tools for electrocoagulation. 9. Power tools. 10. Polymer products. 11. Glass products. Plasma is generated by strong electromagnetic radiation in an atmosphere of hydrogen peroxide vapor. When the electromagnetic field is turned off, free radicals are converted into water and oxygen molecules, leaving no toxic waste. The minimum processing time in a plasma sterilizer is from 35 minutes. The operating temperature is 36 to 680 degrees Celsius. One of the main advantages of this method is the absence of toxic waste. Only oxygen and water vapor are generated. Plasma sterilization destroys all forms and types of microorganisms. Plasma sterilizers are promising equipment, but too expensive. 4. Cold sterilization. This type of sterilization is used on heat-sensitive dental instruments. For this, solutions such as glutaraldehyde or sodium hypochlorite can be used. However, this procedure takes a long time to obtain complete sterilization and is therefore not recommended. However, these chemicals can be used for high-level disinfection purposes. Chemical sterilization with antiseptic solutions. Sterilization with solutions of chemical antiseptics, as well as radiation and gas sterilization, refers to cold sterilization methods and does not lead to blunt instruments, and therefore is used for processing, primarily, cutting surgical instruments. 3 types of solutions are mainly used for sterilization. Triple solution. 96 degrees ethyl alcohol. -6% hydrogen peroxide. Recently, an alcohol solution of chlorhexadiene, Pervomor and others have been used for cold sterilization of optical instruments. For cold sterilization, the instruments are completely immersed open, or disassembled, in one of the specified solutions. When soaked in alcohol and a triple solution, instruments are considered sterile after 2 to 3 hours, in hydrogen peroxide after 6 hours. This method is of interest for the sterilization of solutions containing medicinal substances that change under the influence of high temperature. What antiseptics are used? Phenol, tricresol, quinosol, Nipagen, Nipazole, Chlorotin, Mercurofan and Spirol. There are also reports in the literature on the use of chlorocresol, chlorobutol, phenylmercuronitrate, quaternary ammonium compounds, benzalkonium, cetramide, and some other substances for this purpose. Carbolic acid is part of a ternary solution, cariphenine solution. They sterilize cutting tools and plastic items. It contains sterilized needles, scalpels, forceps, plastic tubes. Lysol with green soap is used for washing walls, floors, furniture of the operating and dressing unit, as well as for treating instruments, rubber gloves, items contaminated with manure or feces during surgery. Sublimate, mercury dichloride. 1 to 1000. 1-3000. Gloves, drains and other items are sterilized. Mercury oxycyanide 1 to 10,000 is used for sterilization of ureteral catheters, cystoscopy and other instruments with optics. Diazide is a mercury preparation that combines antiseptic and detergent properties. Some people use a surgeon to treat their hands. They wash their hands in a basin with a solution of 1 to 3000, 1 to 5000 to 6 minutes. Ethyl alcohol is used to sterilize cutting instruments, rubber and polyethylene tubes. 96% alcohol is used to tan the hands of surgeons before the operation. Although 70 degrees alcohol is more bactericidal than 96 degrees, the spore-like infection does not die for a long time. The causative agents of gas gangrene and anthrax spores can persist in alcohol for several months. To increase the bactericidal activity of alcohol solutions, thymol 1 to 1000, 1% brilliant green solution, Bakel's solution, formalin, etc. are added to them. The bactericidal properties of halogens have been used for a long time. Pirogov used alcoholic iodine 2%, 5% and 10% without knowing about the existence of microorganisms. Iodine has a bactericidal and sporicidal effect. It has not lost its significance even now. However, its complex compounds with surfactants, the so-called iodophores, which include iodonate, iodopyridine, iodolin, etc., are more often used. They are more often used to treat the hands of the surgeon and the operating field. Chlorine compounds have long been used for disinfection, bleach, and sterilization, sodium hypochlorite, chloramine, etc. The bactericidal activity of these drugs depends on the content of active chlorine in them. In chloramine, active chlorine is 28 to 29%, and in dichloroisocyanuric acid, 70 to 80%, sodium hypochlorite minus 9.5%. Hydrogen peroxide, 33% hydrogen peroxide, perhydral, in 3% and 6% concentration is used for sterilization and disinfection. It is harmless to humans. A mixture of hydrogen peroxide with formic acid, proposed by Vidnuk and Melikova in 1970, was named Pershalmer. In the process of preparing C4, supramuric acid is formed, and it acts as the beginning. Used to clean the surgeon's hands or sterilize instruments. In the Czech Republic, they offered PRE-STERIL for sterilization of rubber and polyethylene pipes. Beta-propiolactone was released in Russia. At a concentration of 1 to 1000, Pseudomonas aeruginosa in a 2% solution dies within 10 minutes. It is added in an amount of 0.2% to ready-made nutrient media, which are then incubated for 2 hours at 37 degrees Celsius. If the medium is left overnight, the propiolactone is completely degraded. Liquid chemical sterilizers or disinfectants. For temperature-sensitive critical and semi-critical devices only. Very toxic. Followed the manufacturer's instructions, for example, regarding dilution, immersion time and temperature, and safety precautions. Heat-resistant or disposable alternatives are available. Types of microorganisms in order of decreasing resistance to disinfection and sterilization. By Spalding. Chemicals have the following effects on microorganisms. Bactericidal, the ability to kill bacteria. Bacteriostatic, the ability to suppress the vital activity of bacteria. Sporicidal, the ability to kill spores. Virucidal, the ability to kill viruses. Fungicidal, the ability to kill fungi. For chemical disinfection are used. Chloramine 3%, for tuberculosis infection 5% solution, 60 minutes. Hydrogen peroxide 6%, 60 minutes. Precept 0.05%, 30 minutes, 10 tablets, half a gram each. Lysetal 4%, 15 minutes. 40 milliliters of the drug plus 960 milliliters of water, 5%, 5 minutes, 50 milliliters of the drug plus 950 milliliters of water. Lysoformin 3001%, 60 minutes, 1.5%, 30 minutes, 15 milliliters of the drug plus 985 milliliters of water, 2%, 15 minutes, 20 milliliters of the drug plus 980 milliliters of water. Virkon 2%, 10 minutes, 20 grams of the drug plus 980 milliliters of water. Deciform 1%, 60 minutes, 10 milliliters of the drug plus 990 milliliters of water. 3%, 30 minutes, 30 milliliters of the drug plus 970 milliliters of water. 5%, 10 minutes, 50 milliliters of the drug plus 950 milliliters of water. Diactin 0.2%, 60 minutes, 2 milliliters of the drug plus 988 milliliters of water. For chemical disinfection are used. Desinfect 2.3%, 60 minutes, 3.8%, 30 minutes. Bacillus AF, 15 minutes. Septodor Forte 0.4%, 60 minutes, 0.5%, 30 minutes, 0.7%, 15 minutes. Subtotal, 30 minutes. Gradinate, 30 minutes. Alaminol 5%, 60 minutes, 8%, 60 minutes. Peroxim 3%, 60 minutes. Glutarol, 15 minutes. Chlorhexidine alcohol solution 0.5%, 30 minutes. Alcohol 70 degrees. Disinfection with chemicals is carried out by immersing products in a solution in a special glass enamel or plastic container with a lid. Disinfectant container with gripping forceps of dental is shown in the figure. Means and modes of chemical sterilization. Chemical compounds. 6% hydrogen peroxide solution. 1% desoxone 1 solution. 2, 5% glutaraldehyde solution. 8% lysoformin 3000 solution. 10% gigacept FF solution. 20% bionol solution. Temperature. In degrees Celsius. Exposition. In hours. Are shown in this table. Precautions. Work on the preparation of a working concentrated solution must be carried out in compliance with personal safety measures that ensure skin and eye protection, rubber gloves, goggles. In case of accidental contact of the drug in the eyes, rinse them with plenty of running water for 10 to 15 minutes, drip an albicide solution into the eyes and consult a doctor. In case of accidental ingestion of the drug into the stomach, it is necessary to rinse the stomach with water and consult a doctor. In case of accidental contact of the drug on the skin, rinse the affected area of the skin with running water. If the respiratory tract is affected, it is necessary to remove the victim to fresh air and free him from tight clothing. Milk intake is recommended. It is forbidden to eat and smoke during the work on the preparation of the working solution and disinfection. At the end of work, face and hands must be washed with soap and water. Sterilization by ionizing radiation. Antimicrobial treatment can be carried out using ionizing radiation, Y-rays, ultraviolet rays and ultrasound. Sterilization by Y-rays has received the greatest application in our time. The radiation method or radiation sterilization by Y-rays is used in special installations for industrial sterilization of single-use, polymer syringes, blood transfusion systems, petri dishes, pipettes and other fragile and thermolabile products. The isotopes cobalt-60 and cesium-137 are used. The dose of penetrating radiation should be very significant, up to 20 to 25 microgray, which requires compliance with particularly strict safety measures. In this regard, radiation sterilization is carried out in special rooms and is a factory sterilization method. It is not performed directly in hospitals. Sterilization of instruments and other materials is carried out in sealed packages and, with the integrity of the latter, is preserved for up to 5 years. Sealed packaging makes storage and use of tools convenient, you just need to open the package. The method is beneficial for sterilizing simple disposable instruments, syringes, sutures, catheters, probes, blood transfusion systems, gloves, etc. and is becoming more widespread. This is largely due to the fact that during radiation sterilization the properties of the sterilized objects are not lost at all. Sterilization ultraviolet radiation. Sources of UV radiation. Wavelength 260 nanometers. Are mercury quartz lamps. Their powerful bacteriostatic effect is based on the coincidence of the emission spectrum of the lamp and the absorption spectrum of the DNA of microorganisms, which can cause their death during prolonged treatment with the radiation of quartz lamps. An effective sterilizer that allows you to sterilize surgical instruments and dressings with dry heat and ultraviolet rays. Has a powerful bactericidal effect. With an insufficiently powerful action of UV in the prokaryotic cell, the processes of light and dark repair are activated, that is, the cell is restored. The method is used for sterilization of premises, equipment and boxes, as well as for sterilization of distilled water. Flash sterilization. Instant sterilization. Steam sterilization flash was originally defined by Underwood and Perkins as sterilization of an unpackaged object at 1320 degrees Celsius for 3 minutes at a weight of 27 to 28 pounds of pressure in a gravity displacement sterilizer. Currently, what is required for instant sterilization depends on the type of sterilizer and the type of item, i.e. porous or non-porous items. Flash sterilization is considered acceptable for the treatment of cleaned patient care items that cannot be packaged, sterilized, and stored prior to use. It is also used when there is insufficient time to sterilize the item using the preferred packaging method. Flash sterilizer TrueClaw of 14 liters Class N is shown in this figure. Mechanical sterilization method. Bacterial filtration. The method consists in separating microbes from liquid using sterile microporous filters. The filtration mechanism is mainly due to the adsorption of microbes in the pores of the filter media, which in most cases are negatively charged. Kaolin, porcelain, paper asbestos pulp, infuser earth, collodion and other porous materials, as well as glass are used as microporous filtering material. This slide show. Figure 1. Installation of Chamberlain candles, diagram. 1. Filtered liquid. 2. Filter candle. Figure 2. Glass filters with finely poured glass plates, diagram. Mechanical sterilization method. Bacterial filtration. Mechanical sterilization method using microporous filters has several advantages over heat sterilization methods when the solution is exposed to high temperatures. For many solutions of thermolabile substances, it is essentially the only available sterilization method. Microporous filters are widely used in chemical pharmaceutical plants and in the production of vaccines and serums. How does sterilization monitoring conduct? How to ensure effective sterilization? The quality of sterilization is controlled by visual, physical, chemical and bacteriological methods. The visual method is carried out by monitoring the time, pressure, and the order of the sterilizer operation with the recording of the data of each cycle in the autoclave operation journal. The physical method is based on the effect of melting crystalline substances to a certain temperature. Before sterilization, a test tube with powdered sulfur, benzoic acid, antipyrine or imidapyrine, the melting temperature of which exceeds 110 degrees Celsius, is placed in the bixes. The tube is closed with cotton wool and placed in the bix between the layers of material. If the temperature in the autoclave rises to 120 degrees Celsius, the powder melts in the test tube and turns into a homogeneous mass. The melting indicator at 130 degrees Celsius is urea. In the chemical method, a specially treated strip of filter paper is placed with products to be sterilized. With a simple pencil, they write the word sterile on it, soak it with a solution of starch and dip it into a solution that contains iodine, Lugol's solution. After this treatment, the strip of paper becomes intensely blue and the word disappears. At a temperature of 115 degrees Celsius, iodine evaporates, the paper becomes discolored, as a result of which the indicated inscription appears. For the purpose of operational control, temporary chemical indicators IS 120, IS 130 of the Wiener Company, the Completium 1222 indicator tape of the 3M Company, USA, etc. are placed in the sterilizer, sterilization boxes, as well as outside them. Sterilization quality. The most reliable method is bacteriological control of sterilization. For this purpose, small pieces of material to be sterilized are placed in 2 to 3 test tubes, covered with cotton wool and placed in a bix. After sterilization, the tubes are sent for research to a bacteriological laboratory. If after 2 to 3 days no bacterial growth is observed, the material is considered sterile. The disadvantage of this method is the considerable duration of the study. The control of the steam sterilizer operation using biotests is carried out once every 2 weeks. Mechanical monitoring. Monitor each load with mechanical, physical, indicators. time, temperature, pressure. Chemical indicators, they are temperature-sensitive indicators that change color when exposed to heat or steam. They are used in the form of tapes or strips and are attached to instrument pouches for sterilization control. If instruments are deployed, they are also placed in hard-to-reach places to assess the sterilization level. Use an internal chemical indicator in every package. If the internal indicator is not visible from the outside, then also use an external indicator. Chemical indicators may be integrated into the package design. Inspect indicators after sterilization and at time of use. If the appropriate color change did not occur, do not use the instruments. There are 5 classifications of indicators recognized by the Food and Drug Administration. Class 1. Process indicators. These are placed on the outside of packs and are useful in determining which packs have been properly processed versus those that have not. Class 1 process indicators include autoclave tape and the color change indicators embedded on the outside of sterilization packaging materials. Class 2. Boedic indicators. These show the pass/fail in pre-vacuum sterilizers. This test is conducted daily with the chamber empty, 10, during the first cycle of the sterilizer, and is available as a kit from commercial sterilization monitoring companies. Class 3. Temperature-specific indicator. These react to one of the critical parameters of sterilization and indicate exposure to a specific value such as temperature or psi. Class 4. Multi-parameter indicators. These react to 2 or more of the critical parameters in the same manner as Class 3 indicators. Class 5. Integrating indicators. These are designed to react to all critical parameters of sterilization cycles. When used properly, integrating indicators may serve as the basis for the release of processed items, excluding implants. It is important to follow the manufacturer's specific instructions for use regarding a test challenge pack. Biological monitoring. The use of biological monitors, spore tests, is the most reliable method to validate that the sterilizer is functioning and that the sterilization of instruments is effective. These monitors consist of paper strips or vials impregnated with bacterial spores that are specifically resistant to the sterilization process. New spore tests have been developed that enable completion of biological monitoring in office and yield results in as little as 24 hours. These tests allow quick remediation and validate proper infection control procedures without a long lag time during which the sterilization procedure may have become ineffective but is not known. It is recommended that biological monitoring be conducted at least weekly and with every load that includes an implantable device. Biological indicators. This type of sterilization test uses highly resistant bacterial spores such as Bacillus stearothermophilus, used as an indicator for steam and chemical sterilization, or Bacillus subtilis, for monitoring dry heat sterilization. Assess sterilization process directly by killing known highly resistant microorganisms. Use biological indicators, spore tests, at least weekly. Accounting management. Record keeping. Sterilization monitoring, for example, biological, mechanical, chemical, and equipment maintenance records are important components of a dental infection prevention program. Ensures cycle parameters have been met and establishes accountability. If there is a problem with a sterilizer, documentation helps to determine if an instrument recall is necessary. Storage of sterile and clean items and supplies. Store clean items in dry, closed, or covered cabinet. Use date or vent-related shelf life practices. Examine wrapped items carefully before use. When packaging of sterile items is damaged, clean, repackage, and heat sterilize again. Cleaning and disinfection strategies for blood spills. Strategies for decontaminating spills of blood and other body fluids differ by setting and volume of the spill. The person assigned to clean the spill should wear gloves and other personal protective equipment as needed. Visible organic material should be removed with absorbent material, for example, Disposable paper towels discarded in a leak-proof, appropriately labeled container. Non-porous surfaces should be cleaned and then decontaminated with either an hospital disinfectant effective against HBV and HIV or an disinfectant with a tuberculocidal claim, that is, intermediate-level disinfectant. However, if such products are unavailable, a 1:100 dilution of sodium hypochlorite, for example, approximately 1/4 cup of 5.25% household chlorine bleach to 1 gallon of water, is an inexpensive and effective disinfecting agent. Handpiece asepsis. Handpieces for the drills are disinfected according to the generally accepted method after each patient. As a rule, the disinfection of dental handpieces is carried out by thoroughly wiping the outer parts and the burr channel twice with a sterile cotton gauze swab moistened with 70 degrees alcohol or Bacillus AF. The interval between wipes should be 15 minutes. To reduce internal contamination of the turbine handpieces, a water jet is passed through the handpiece connected to the compressed air system for 30 seconds, and then the handpiece is disconnected and lubricated with a spray cleaning system. The most common way to sterilize handpieces is autoclaving. It is carried out following a number of rules. Only dry instruments are placed in the autoclave. Before autoclaving, the tip is packed in an airtight package, which is sterilized. Autoclaving is carried out only with distilled water. Chemical autoclave is excluded, at a temperature of 134 degrees Celsius and a pressure of 2.2 atmospheres, at a temperature of 121 degrees Celsius and a pressure of 1.1 atmospheres, or follow the recommendations of the autoclave manufacturer. The handpieces are removed from the apparatus immediately after autoclaving and stored in sterile packaging. For disinfection of handpieces and other dental instruments, a device is currently used, Terminator. Cleaning, disinfection and decontamination with the Terminator is a combination of mechanical and physical processes. When a dental instrument is inserted into the Terminator tunnel, the photocell automatically turns on 4 high-pressure tubes, from which a disinfectant solution is supplied. These tubes do their job under a pressure of 3.5 atmospheres. Anything that covers the instrument is sucked out by a powerful fan using the Venturi effect through the sluices. Waste, blood, dust, tissue or powder residues are securely enclosed in a specially integrated container, where all microorganisms are killed. At the same time, the instrument is disinfected with a high-pressure spray. The figure shows purification apparatus Terminator and disinfection of instruments during treatment. Electromedical system, France. Dental mirror asepsis. Mirrors are subject to disinfection, pre-sterilization treatment and sterilization by steam, air or chemical methods, in accordance with the instructions. The working part can be sterilized in a glass purlin sterilizer. For chemical disinfection of dental mirrors, a 6% solution of hydrogen peroxide is used. The processing time is 60 minutes. After the end of the exposure, the mirrors are rinsed with sterile water, wiped with a sterile napkin and stored in a sterile tray under a sterile napkin. Glasses for mixing filling materials are processed by the above methods and sterilized by steam in an autoclave. Before and after use, light guides for photopolymerization lamps are thoroughly wiped twice with a sterile napkin moistened with 70 degrees alcohol or 4% Lacetol, AF solution. 8. Environmental infection prevention and control. Preventing transmission of respiratory pathogens in hospitals requires the application of infection control procedures and protocols including environmental and engineering controls, administrative controls, safer work practices, and personal protective equipment. Measures that enhance early detection and prompt triage and isolation of patients are critical to ensuring effective implementation of infection control measures. Successful implementation of these strategies is dependent on the presence of clear administrative policies and organizational leadership that promote and facilitate adherence to these recommendations among the various people within the healthcare setting, including patients, visitors, and healthcare personnel. Cleaning the premises of the dental department. Current disinfection in general and office premises, reception, corridors, waiting room, changing room, etc., is carried out 2 times a day, before and at the end of the working day, by wet cleaning using 0.1% desacting solution or other disinfectants funds. The door, windowsill, tables and solid furniture are wiped with a cloth soaked in one of the disinfectant solutions. General disinfection, in rooms for medical and diagnostic purposes is carried out once a week, which includes the following steps. Stage I. Mechanical cleaning by washing the ceiling, walls and floor using a detergent, Lotus, Biomoy, etc., in a concentration of 0.5%, 50 grams of detergent per 10 liter of water, or 2% soap and soda solution in the system of 2 buckets, container number 1 and container number 2. The rag is moistened in container number 1, detergent solution, thoroughly wiped an area of 2 to 3 squared, with it, rinsed in container number 2, clean water, wrung out, moistened again in container number 1 and washed new surface areas. Water in container number 1 is changed as it gets dirty, and in container number 1, after washing the surface of 60 squared. Stage 2. Disinfection of the ceiling, walls and floor with a 6% hydrogen peroxide solution or a 0.5% desacting solution using a system of 2 buckets with an exposure time of 60 minutes. Then the treated areas are washed off with clean water. Stage 3. Quartzing the premises for 2 hours using bactericidal ultraviolet emitters at the rate of 1 watt of lamp power per 1 cubic meter of the room with further ventilation. Dental unit water quality. Dental unit water lines, that is, plastic tubing that carries water to the high-speed handpiece, air, water syringe, and ultrasonic scaler, promote bacterial growth and development of biofilm due to the presence of long narrow-bore tubing, inconsistent flow rates, and the potential for retraction of oral fluids. Dental healthcare personnel and patients could be placed at risk of adverse health effects if water is not appropriately treated. All dental units should use systems that treat water to meet drinking water standards, that is, less than or equal to 500 CFU per milliliter, column-forming units, of heterotrophic water bacteria. This figure shows, clean water system, of a dental chair performer, ETIQUETTE, USA. Independent reservoirs, or water bottle systems, alone are not sufficient. Commercial products and devices are available that can improve the quality of water used in dental treatment. Consult with the dental unit manufacturer for appropriate water maintenance methods and recommendations for monitoring dental water quality. During surgical procedures, use only sterile solutions as a coolant, irrigant using an appropriate delivery device, such as a sterile bulb syringe, sterile tubing that bypasses dental unit water lines, or sterile single-use devices. Conclusion. Pervasive increases in serious transmissible diseases over the last few decades have created global concern and impacted the treatment mode of all healthcare practitioners. Emphasis has now expanded to assuring and demonstrating to patients that they are well protected from risks of infectious disease. Infection control has helped to allay concerns of the healthcare personnel and instill confidence in providing a safe environment for both patient and personnel. Resources. Centers for Disease Control. Guidelines for Infection Control in Dental Healthcare Settings, 2003. Centers for Disease Control. Guideline for Disinfection and Sterilization in Healthcare Facilities, 2008. Centers for Disease Control. Summary of Infection Prevention Practices in Dental Settings. Basic Expectations for Safe Care, Resources to use in the event of a reprocessing error or failure. Centers for Disease Control. Healthcare Associated Infections Website, Outbreaks and Patient Notifications. Patel P.R., et al. Developing a Broader Approach to Management of Infection Control Breaches in Healthcare Settings. MJ Infect Control. 2008 36 685 690. Rutala W.A., et al. How to assess risk of disease transmission to patients when there is a failure to follow recommended disinfection and sterilization guidelines. Infect Control Hospepidemial. 2007 28 to 146 to 155. A.K. Condren. Disinfection and Sterilization in Dentistry. Texas Dental Journal, Volume 131, Number 8, pages 604 to 608, 2014. M. Sakuchi, G. Irardo, C. Prodino, M. Vitali, and A. Polimeni. How to Manage the Biological Risk in a Dental Clinic. Current and Future Perspectives. Minerva Stomatologica, Volume 66, Number 5, pages 232 to 239, 2017. Acknowledgements. A special thank you to the free text-to-speech for U.S. English language TTFMP3.com. Thank you for your attention. Yours sincerely, the Associate Professor, M.D., Ph.D., EDM. Vyacheslav Tamilan.